This is the Big Ideas Theater at AARC. I'm Ed Highland, and I'm joined once again by Thomas Perreno,
Thank you,
who
Ed.
has been with us in the past, St. Michael's Hospital out of Toronto.
Yep.
We're talking about diaphragm protective ventilation. First, the big question, what is it?
So this concept of diaphragm protective ventilation is probably new to most respiratory therapists in terms of hearing that terminology. Lung protective ventilation, on the other hand, everyone has heard of lung protective ventilation, and if you haven't, you need to understand that, because that's the basis of how we should be protecting patients' lungs that are on mechanical ventilators in the ICU. But what goes often sort of, I wouldn't say ignored, but under-recognized is the effect that mechanical ventilation can have on the diaphragm. Now, most clinicians would probably understand that if you completely control a patient and don't allow them to breathe, the diaphragm will experience atrophy. And in fact, this atrophy occurs very quickly, within 18 to 69 hours. So this atrophy can occur very quickly. So the question is, okay, do we want the diaphragm to work? Probably. But diaphragms can then excessively work, and then we run into different problems of lung protection, diaphragm injury from excessive loading of the diaphragm, giving them too much work. And then we get to this problem where, okay, we want to protect the diaphragm from atrophy by letting it work, but now we have to consider whether or not the work we allow it to do is causing injury in another area. So this diaphragm protective ventilation, the concept is, can we keep the inspiratory effort of the patient in an acceptable range that also protects the lungs? And that's the second part of the question is, can diaphragm protection actually exist? I don't know. With lung protective ventilation is questionable.
I was going to say, can they? So it's still a question. You just
It's still
don't
a
know?
question, yeah. So we know that lung protective ventilation is important. And again, one of the things we often don't understand is that when patients are breathing spontaneously, they generate something called dynamic transpulmonary driving pressure. And it's very difficult to understand and measure at the bedside because you can't see the effort they're making per se. It's like the iceberg effect. You see the pressure we're delivering on top, but what's happening below the water? So how much effort are they generating, because that effort contributes to the total amount of strain on the lung. And of course, if it's a lot of effort, it can potentially injure the diaphragm. So what we know now is that lung protective ventilation is important. We haven't looked at it closely enough during spontaneous breathing, and that brings us to light of, okay, if they can injure the lungs during spontaneous breathing, is it injuring the diaphragm as well? And we have growing evidence, a lot of it coming out of the work through Dr. Ewan Gallagher, that inspiratory effort, excessive inspiratory effort, prolongs time on the ventilator and impacts outcome. So we have this issue now that patients can possibly cause what's called self-inflicted lung injury. And this is a new concept, because lung injury, we assume, just take over the ventilator, don't let them breathe for a bit and then get them breathing. But what if a patient can actually generate further lung injury? And so the answer to whether or not lung protective ventilation can occur with diaphragm protective ventilation has not been tested, so we don't know the answer to that question. But I do know that Dr. Ewan Gallagher is working on protocolizing an approach to targeting a diaphragm activity within an acceptable range, but monitoring the dynamic transpulmonary pressure that's being generated to ensure that we try to balance one with the other. Whether or not we can we don't know. We'll find out hopefully soon.
So what of the poor clinician, how do they come up with a strategy to perhaps protect the diaphragm?
So the first and foremost thing to do is to understand methods and ways to actually monitor inspiratory effort. So if you're not monitoring inspiratory effort, you have no clue whether or not it's excessive or not. Having said that, if you walk up to a bedside and a patient is clearly indrawing and working hard to breathe, you could say, okay, they're probably breathing hard and excessive. But on the flip side, someone who's breathing on a ventilator may not be making much effort at all, and the ventilator is doing all of the work, which gets into the atrophy side of things. So some things are obvious, some are not, and some patients may look like they're working hard because they may be a bit uncomfortable, but it's actually within an acceptable range and maybe not contributing to lung injury. So first and foremost, measure inspiratory effort. There's a number of ways to do that. Every ventilator has what's called the P0.1. It's an occlusion pressure that the ventilator will do or estimate. It's the first 100 milliseconds of a breath when the patient triggers the ventilator, and that delta pressure, that change in pressure that occurs in that first 100 milliseconds, can indicate the amount of drive the patient has. So when it becomes a number, for example, greater than 5 or 6, it's probably excessive effort. If it's 0.5 or 1 in a ventilated patient, it's probably too low. So at least acknowledging that values exist that we can monitor simply at the bedside with ventilators we already have. Every ventilator has that number. That's what's interesting. And then some work currently being done, again, by Dr. Ewan Gallagher. He's sort of the diaphragm guru right now in our world. He's done some work where doing a brief pause on the ventilator, an expiratory hold, and measuring the drop in pressure, they call this an occlusion pressure as well, measuring that pressure can predict, again, they both internally and externally validated this, it can predict PMUS, which is the amount of muscular pressure required for the patient to work, to do the work of breathing, and dynamic transpulmonary pressure, driving pressure. So now you have one simple maneuver that put into a simple calculator, for example, can determine whether or not you're in a range of lung and diaphragm protective ventilation. The caveat is, hasn't been tested in a formal trial yet. So we now have potential tools to help us understand this, but whether or not they change outcomes has yet to be determined.
So it's keep your ear to the ground and listen
Absolutely,
for the latest data to come out.
Watch the work coming out of Toronto. That's what all I can say about that.
All right, well, Tom, thank you so much for coming by once again.
Thank you very much for having me. Appreciate it.
And this is the Big Ideas Theater at AARC. I'm Ed Highland.